Okay, so let's just discuss the notes of retained placenta first. So usually we know that this active management of third stage, it usually lasts for 5 to 10 minutes. Okay, so if 5 to 10 minutes have passed and still you are unable to deliver the placenta, and then the threshold is 30 minutes. If within 30 minutes the placenta has not separated, then we define it as a retained placenta. So you should know this definition, that within 30 minutes, despite the AMTSL and you have done the modified Brandt Andrews method properly, still it has not separated, then this is a retained placenta now. This retained placenta can either be trapped or adhered. Now, these are the two categories of retained placenta. Now, what is a trap placenta? A trap placenta is that which has separated, but still it is inside the uterus. It has not come out. Why? Because the uterus is contracting very, vigorously, and a constriction. This is called a constriction ring. A constriction ring has been formed, and that is why the placenta is, yeah, the placenta is unable to deliver. Now, in this case, the uterus is contracted and the fundus will be high. And now the second category can be placenta adherence, in which it has not even separated. In the trapped one, it was separated but still was not unable to come out of the introitus. In this case, it has there is failure to separate. Okay, now the thing is that in the first type, the trap placenta, we discussed in the AMTSL that methergin should be used very cautiously as a uterotonic, because it causes the formation of a constriction ring and a trapping of a placenta. So if there is, in a scenario they have mentioned methergin use and all the other signs of retained placenta, then you're going to say that it is a trap placenta. Okay, and then there can be placenta accreta. Now in case of placenta accreta, what happens is the placenta has invaded myometrium, so it has become a part of it, it has invaded it, so it's an accreta, it's an invasive placenta. In adherence, what was happening, the myometrium was not able to contract, but in this case accreta has invaded the myometrium, so even if it contracts, it is not going to separate. So these are the three categories that we have discussed now. The thing that the problem is that if you somehow separate the retained placenta, a lot of bleeding is going to happen, because the uterus will become atonic at that point. Now, what are the risk factors? If there's a prior history of retained placenta, of course, if you know that you're suspecting that myometrial contractility is going to be poor, then of course in that case, if there is a premature contraction of low uterine segment, use of methergin. If there's a prior uterine scar, why? Because when there's a scar, now the portion of the uterus that has a scar is not able to contract properly. Okay, so poor uterine contractions, or they are not going to be in sync. Then we have uterine anomalies, septate or biconvate uterus. So all these are the risk factors for retained placenta. So now you have a patient and you know that almost 30 minutes have passed and the placenta has not been delivered, and you're like, okay, so this is a retained placenta. How are you going to proceed now? What are you going to do? So basically the algorithm for retained placenta is very easy. You have to ask one question. Is the patient bleeding? Okay, is the patient bleeding or not? If there is no bleeding, then you can wait. Okay, you can wait further, that it might deliver on its own. Okay, so you can wait for 60 minutes maximum, but this is theoretical, it's very risky, don't do it. So the thing is that whenever you have a case of retained placenta, always resuscitate right away. So resuscitation is to be done first. Okay, and after resuscitating the patient, then ask the question that is the patient bleeding. If the patient is not bleeding, then you can wait, and if and you can also start a uterotonic infusion. You can give uterotonic if you think that maybe the uterus is not contracting properly, and then before attempting the manual, and then you can attempt manual removal of placenta. Okay, but let's say that there is bleeding and the patient is getting unstable despite resuscitation. In that case, you have to give general anesthesia right away. MRP, I'm going to just discuss the steps. It is always done under general anesthesia, and then you're going to go for MRP. Proceed. You can also do surgical removal of placenta. Now, what is MRP? So first of all, MRP is preferred to be done in OT. Okay, under general anesthesia and under antibiotic cover. These things are a must. Okay, these are no brainers. Otherwise, you're going to give rise to another problem. You might give rise to sepsis if you don't do it in aseptic conditions under antibiotic cover. And then with or without tocolytics, your choice depends on the condition of the uterus. If there is a contraction, if there's let's say if there's a constriction ring has been formed because of methergin use, then in that case you are going to give a tocolytic now, because the lower uterine segment is over contracted. So you have to see the state. Based on that, you can or you cannot use a tocolytic. So these are the prerequisites that you have to fulfill before starting MRP. Now, how are you going to do MRP? one hand, just like in modified Brand Andrews method, I told you that one hand is to be placed over the uterus. So in this case also one hand is placed over the uterus, okay, to prevent the displacement of uterus. And with the other hand you are going to introduce it inside the introitus in a cup shaped, in a cone shaped manner. You're going to introduce it inside the introitus, and you're going to try to find the plane of the cleavage behind the placenta, and then you have to find the plane of the cleavage, and then sweep your hand over it, and then you're going to it's going to be it will come off if it is not morbidly adherent. Okay, if it is adherent then it will not come out, this will fail. Adherent, then this will not work, otherwise easily it will come off. Okay, and after doing this also you have to make sure, after doing the manual removal of placenta, you have to make sure that the uterus is contracting properly. Okay, so you have to rule out atony after this, otherwise severe PPH can occur, because you already placed your hand inside the uterus. So it's very it was rather invasive procedure, so you have to make sure that this is done properly. Now what are the complications that can occur? We know that with this MRP, as I said, that if these things are not fulfilled, then sepsis can occur. We are giving general anesthesia, so anesthesia related complications can occur, and uterine rupture can occur, very important complication, and infection and sepsis. So all these are all the things.